of abstracts related to PMTCT and pediatrics. And then Dr. Fowler was not able to be on the call, so I'm going to discuss the findings from PROMISE. And I believe we're going to stop for questions and discussion and then move on and present three other abstracts that were presented at the meeting by the people who actually presented them. So,
Dr. Matheson?
yes.
Yes, if you can stay close to the speakers, you were a little distant. Now it's much better.
Okay.
But at first you were distant.
Leaning right over my computer. Is that okay?
It sounds a little distant, but at times you're clearer. So,
Well, let me see.
yeah, that sounded a little better.
Okay. Well,
Okay.
give it a try. Just
Right there, that's fine. That's perfect right there.
okay.
Okay.
All right. So first, we're going to talking about some of the abstracts from pregnancy. I see that people are saying they can't hear. Um, I don't know exactly what I can do other. Let's see if I can try it. Is that better for people?
Um, it's a little, yeah, it's a little low. Do you have headphones that you can
I do
use?
have a phone.
Or headphones?
No, I don't have headphones.
That might help. That usually helps.
Well, but I don't have
Oh,
headphones.
okay, sorry. I didn't hear that.
If you want to try to call me.
Okay, well, I'll see if we can do that. Hold on one moment.
Okay.
Okay.
Sorry, folks. Yeah, because people are saying they can't hear. It's because I'm not talking because we're trying to figure out whether we can do this with someone calling me.
Hello?
Yes, I'm here.
Yes, and you're close to your speakers, Dr. Matheson?
I'm leaning directly over my computer. Hello?
We'll try to dial you in, but it might be the same quality. Hold on. If you can mail me, I'll call you on your cell phone.
Okay, no, let me just.
Okay.
It's should. Hello? 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 Yes. My home phone might be easier to do. Yes, 301 236 9319. Jessica, I just put it into the chat. Jessica? Hello?
Hi, Len. We can hear you. I don't know if Jessica is on mute as well.
Okay, well, I just said.
Hello? Hello?
Yes, do you have the number?
Yes, I'm dialing, but there's no guarantee it'll work. So,
Okay.
but let's see.
I'm not quite sure how to make this any louder than I currently am.
Yeah, I mean, you're although it's just the quality of the speakers in the computer, I think. And you don't have music headphones or anything like that you can use? That sometimes helps.
No,
No, okay.
I'm at home, so.
Okay. Yeah, you're clear now, so
Well, this is where I've been kind of before, but I can.
okay. It's much better though. So
All right. What would you like to do?
I think perhaps just go ahead because I don't think that the phone's gonna have any more, better quality.
Well, why not? Usually the phone is better,
But for us to link it to the webinar, it's not on our end. Our speakers will go lower too because then I have to take out my headphones.
okay.
Yeah.
Just tell me if there's problems. So should I start?
Yes.
Okay. So, hi everybody again. So let's see whether this works with me, like sitting on my computer here. So the first presentation I'm going to talk about is from the study in Alberta. So in April 2012, Alberta started to implement option B plus. And the Tobago study is a study that's evaluating option B plus that started in April 2013. So it enrolled 608 women who were enrolled in the third trimester or up to 2 weeks postpartum from 14 clinics in Rwanda. Many of the women had been on treatment prior to entering the study. The median duration of antiretrovirals was 13 months. 52% were undetectable at enrollment, and undetectable was defined as less than 20. And detectable viral load at entry was associated with lack of education, side effects from the drugs in the past month, but most importantly, shorter duration of antiretroviral drugs. And if we first look at this little graph, this is looking at duration from 0 to 36 months. And you can see that in women who received more than 4 months of drug, there was about 70% of those women were undetectable compared to 30% who were undetectable with less than 4 months. And if you then move and you look, hone in on the less than 4 months, you'll see that this is really in women who were receiving less than 1 to 2 months of treatment. So 66% of women who received 4 months of treatment were undetectable, whereas only 4% of women who received less than 4 weeks were undetectable. So the most important, to me, the most important factor associated with detectable viral load and delivery was very short duration of treatment, less than 4 to 8 weeks. This is from the French perinatal cohort. looking at the impact again of treatment duration and viral load and correlating that with mother-to-child transmission. The overall transmission in France is extremely low, 0.7%. And in 2,651 women who were starting treatment before conception and had already less than 15 at delivery, they had no transmissions whatsoever. You can see in the little graph, women who started before conception all had pretty low transmission rates, even with a viral load over 400, you can see it's still less than 200. But as you move up in terms of when the drugs were started, regardless of their load, you see the transmission rate moves up. So transmission was 0.2% if you started before conception, 0.4% starting in the first trimester, 0.9% in the second trimester, and 2.2% in the third trimester. So these data are very consistent with the Tobago data that you just saw, suggesting that short duration treatment is associated with detectable viral load, and detectable viral load is associated with risk of mother-to-child transmission. These are data from Botswana. So Botswana had been operating on option A, and then moved to option B, implementation countrywide in January 2013, which is the little red dot here. And this slide shows you trends in antiretroviral drug use over time in Botswana. So if you look at the January 2013 as the delineation point, 59% of women were receiving triple drugs before January 2013 compared to 79% after January 2013. So you see option B plus was being successfully implemented. So if we look at the results here and we compare HIV transmission rates, you can see that HIV transmission was significantly lower once they moved to option B, with the transmission in infants born between 2011 and 2012 being 1.6.
Hello? 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 But you can't hear me. Hello? Can everyone hear me?
Jessica, we can hear you. I'm not sure.
We have two options. We lost Lynn, I can see that. So we can either I think maybe we can go on to the three abstracts, assuming the audio quality is better, which it should be, because Karina and Dr. Maman were audible. So
I think why don't we try moving on to those, and then we can see if we can get Lynn on the line.
Okay. So while we try to connect with Lynn, we'll move on to the three abstracts that we have featured on the webinar. And the first is by Dr. David Maman, who is a French medical epidemiologist. He's been working since 2010 in Paris for the Epicenter of Médecins Sans Frontières, MSF, at the Research Center in Epidemiology. And after numerous years of working in the field as a clinician in Burkina Faso, India, DRC, and Morocco, and doing his PhD on immune reconstitution on ART and subsequent mortality, he has been working for the last 3 years on population surveys aiming at measuring HIV incidence at each step of the cascade of care in high prevalence settings in Kenya, South Africa, and Malawi. And that is what he will be presenting on today. His other research topics are hospital mortality and morbidity and aging with ART in sub-Saharan Africa. Finally, he is also supervising a multi-centric cohort study aiming at introducing new HCV treatment based on sovosivir and other DAAs in resource-limited settings. So without further ado, I will turn it over to Dr. Maman, who will be presenting on the study he delivered at CROI on most breastfeeding women with viral load are still undiagnosed in sub-Saharan Africa. So, Dr. Maman, I'm loading your presentation now.
Okay, can you hear me?
Yes, we can hear you very clearly.
That's great.
Okay.
That's great.
Wonderful.
That's a good news. That's a good news. So, thank you for inviting me.
Yo, you're most welcome.
Okay.
We're privileged to have you. So if you choose take over as presenter on top, you can change your slides.
Okay.
Do you see that?
Okay, thank you.
Okay, great.
Yes.
So,
okay, great, perfect.
Okay, wonderful.
It's loading.
Yes.
And I'm almost there. Perfect. Okay, so thank you for inviting me and to be so many to join this presentation. Okay, it's exactly the presentation I did at CROI. So I present last around 10 minutes, as you said, and after we can go for the questions. So as you know, maternal HIV viral load is a strong predictor of mother-to-child transmission. However, few studies have assessed population viral load suppression and cascade of care among pregnant and breastfeeding women in sub-Saharan Africa. The cascade of care is a conceptual representation of each step that an HIV-infected individual has to go through to reach undetectable viral load, from diagnosis to linkage and retention in care, ART initiation, and viral load suppression. These key indicators are important to evaluate for planning PMTCT programs. The primary objective of this analysis is to assess population viral load among pregnant and breastfeeding women. We also assessed each step of the cascade of care, measured HIV prevalence, and quantified the proportion of women who got infected during pregnancy and breastfeeding. This study is a secondary analysis of 3 population surveys conducted in the general adult population in 3 districts in 3 different sub-Saharan African countries with high HIV prevalence. The first site was in Shirazulu in Malawi, where option B+ was implemented at the time of the survey. The second site was in KwaZulu-Natal, South Africa, with option B at the time of the survey. And the last site was in Kenya, close to in the Nyanza province, close to the Victoria Lake, where option A was implemented. When we conducted the surveys, MSF was already supporting the programs in Malawi and South Africa, but not in Kenya. The surveys are multi-stage household population-based surveys, which recruited all individuals aged 15 to 59 in the randomly selected household. Each studies lasted 13 weeks, and they were conducted sequentially from September 2012 to November 2013. Here are the study procedures. Following a household questionnaire aiming at identifying eligible household members, interviewers conducted an individual questionnaire to agreeing participants. This questionnaire collected socio-demographic, behavioral, and HIV test-related information, and for women specifically, information regarding the number of births, breastfeeding practices, and ANC attendance. Participants were then tested for HIV using serial rapid test algorithm. All tests were lab confirmed either by ELISA for positive cases or by NAT for negative, except for in Malawi, where we didn't do NAT for all the negative. Then all positive individuals had their CD4 and viral load assessed, and we also measured incidence using recent infection assay. Infection during pregnancy or breastfeeding was defined as an HIV positive test among a breastfeeding woman who was unaware of her status and reported a negative HIV test during antenatal care. Let's now move to the results. As you can see, almost 10,000 households were included, and among the 12,000 women eligible, more than 92% agreed to participate and were subsequently tested for HIV. The proportion of women pregnant or breastfeeding was higher in Malawi and in Kenya, above 33%, compared to South Africa, 12%. If we were to look only at women aged 15 to 30, this proportion of women pregnant and breastfeeding would reach 50% in Kenya and Malawi. Median age was similar across all sites, around 25-year-olds. HIV prevalence among pregnant and breastfeeding women was higher in Kenya and South Africa at 22 and 23% respectively, compared to Malawi, 13%. In the three sites, the proportion of women attending at least one ANC visit was high, at 95%, but the proportion of women who attended at least 3 ANC visits was lower, ranging from 73% in South Africa to 86% in Malawi. I would like you now to pay attention from 85% in Kenya to more than 90% in South Africa. However, as we move now to the cascade of care, you can see that if the proportion of women tested at ANC is roughly similar across sites, the proportion of women who were diagnosed for HIV varies greatly, as it shows in the first column, from 50% in Kenya to more than 80% in Malawi. In sites where option B and B+ were implemented, you can see that there is little loss in the cascade of care once people have been diagnosed. Whereas in Kenya, where option A was implemented, there is a significant proportion of women on care who were not receiving ART. Let's look now more in detail in the population viral load. The proportion of pregnant breastfeeding women with viral load below 1,000 copies was almost 3 times higher in Malawi, 72%, compared to Kenya, 23%. It was also high in South Africa at 63%. However, even in Malawi, we can still see that 12% of the pregnant and breastfeeding women had a viral load above 100,000 copies per milliliter. Let's now look at the distribution of women with viral load above 1,000 copies. In this slide, to be conservative, we have restricted the population to breastfeeding women, acknowledging that pregnant women can still be diagnosed for HIV. What we see is that the majority of breastfeeding women with viral load above 1,000 copies were still undiagnosed. And among them, the majority of these undiagnosed breastfeeding women had been tested at ANC, and then, which it signified that they were infected during pregnancy or breastfeeding. They represent 38% of the total proportion of breastfeeding HIV positive women with high viral load. The last slide presents a proportion of breastfeeding women who reported being infected during pregnancy or breastfeeding. The proportion was 3 times higher in Kenya, 7%, compared to Malawi, 2.1%. South Africa is in the middle at 4.9%. In the frame at the bottom of the slide, you can see HIV incidence among young women aged 15 to 29 measured using recent infection assay. Even if the confidence interval are large, incidence was found higher in Kenya at 3.8 new cases per 100 person year, compared to Malawi, 0.9. This analysis provides a global vision of different sites at high HIV prevalence in sub-Saharan Africa, at different stages of the outbreak dynamic and at different PMPCT programs were implemented. The proportion of pregnant and breastfeeding women with viral load below 1,000 copies range from 27% in Kenya to 72% in Malawi. The proportion of women undiagnosed was higher where incidence was high, suggesting the importance of HIV infection during pregnancy and breastfeeding. Finally, we found that the majority of women with viral load above. This study has some limitation. Despite being representative of the general population and with high inclusion rate, all data except laboratory data were self-reported by participants. We also did not measure HIV prevalence among children of these women, and despite having included 12,000 women, number of HIV positive women remained low. Our recommendations to our field was first to implement B+ wherever it's possible and follow WHO recommendation, as it is the easiest thing to do. However, this data suggests that option B+ may not be enough, and that successful PMTCT program must decrease HIV incidence among young women, either through treatment as prevention or pre-exposure prophylaxis. A broader approach to PMTCT is required. Finally, women at high risk of transmitting HIV to their children and their infants must be searched where they are, meaning outside the PMTCT cohort, at delivery, EPI, ANC testing, where testing needs to be repeated at each visit, but also in nutrition ward, pediatrics, and OPD. Finally, it is possible that these women who got infected during pregnancy or breastfeeding may have already vertically transmitted HIV during acute phase infection because of the high viral load during this stage. Therefore, investment must be still made, despite B+, to improve early infant diagnosis. I would like to thank all our study partners from everywhere who participated to these studies. Thank you very much.
Thank you. Thank you, Dr. Maman, for your presentation. And we'll take questions and answers after the second presentation by Dr. Karina Butler. But feel free, for all of our guests, to send in your questions online. Okay? So, Dr. Butler, I'm going to load your presentation and turn it over to you.
Hi, this is Linda. What do you want me to do?
Okay.
Okay. It's loading. Give it a second.
Hold on a second.
And then if you see up top, it should say take over as presenter.
Okay, so you can hear now.
Yes.
Okay, so and when you hover over, do you now have a microphone?
Okay. Great. It seems to have transferred over, and we can hear you clearly. I'd like to introduce Dr. Karina Butler, who is a consultant pediatrician, infectious disease specialist, and clinical professor in pediatrics. She is also the head of the Rainbow Clinic, the National Center for HIV Medicine and Children at Our Lady's Children's Hospital. and the Children's University Hospital in Dublin, Ireland. She is the member of PENTA, which is the Pediatric European Network for the Treatment of AIDS. She's a member of the steering committee at PENTA and is chief investigator of the Breather trial, which she will be discussing today, and which was presented at CROI last month. So without further ado, I'll turn it over to Dr. Butler.
Hi, well, good morning or good afternoon, depending on where you are. And again, thank you very much for inviting me here to share this information with you. And I'm very happy to be here to present Breather. And I'm presenting on behalf of all our investigators in the PENTA Treatment Network. So Breather is a strategy trial that aimed to look at whether children or young people might be safely given 5 days of antiretroviral therapy rather than 7 days therapy. So that was short cycle therapy versus continuous therapy. In treating HIV infected young people, our goals are to maximize the benefits of antiretrovirals while minimizing long-term toxicity. We wish to maintain long-term adherence to prevent the emergence of viral resistance and to preserve future treatment options. But there are many challenges that face young people as they move from childhood through adolescence. The concept of lifelong therapy, difficulties with adherence.
Dr. Butler?
Or to go outpatient this for the one. Yes, yes.
Dr. Butler, you're going in and out a little bit.
Okay.
Okay.
I'll try and sit
Yeah,
closer.
now it's much better. Yes. Much
Is that better? Okay.
Yes.
So there is a need for new treatment strategies.
Hello, Dr. Butler? Dr. Butler? Can you hear me? No one has been muted. Hello?
Hello?
Yes.
Can you? Yeah,
Yes.
okay. There we go. Okay, can you hear me?
Yes.
Okay.
Feel free
Sorry
to
about that.
continue. It's okay.
So, one possible option in terms of simplification is to exploit the pharmacokinetic parameters of some of the drugs that we have, particularly those with long half-lives, to see if we could give young people their treatment 5 days a week and have short breaks at weekend, that is short cycle therapy. And this would allow for simplification, potentially with less toxicity, might improve adherence, and could result in significant cost savings. I'm sorry, this isn't responding to me.
Okay. Okay, I can, if you want to say change slides, I can change the slides for
Okay,
you.
change slide.
Yes. Slide 4, right?
Yeah, slide 4.
Mm-hmm. We're on slide 4.
I'm only seeing slide 3.
There you are.
Okay, so Breather It was a global phase 2 randomized multi-center non-inferiority trial that was set up to examine the hypothesis that short cycle therapy could be as efficacious as continuous therapy using a drug with a long half-life, i.e. a efavirenz-based first-line therapy. And the population selected for this were young people aged 8 to 24 years of age who had been stable on their antiretroviral regimen, fully suppressed on efavirenz plus 2 NRTIs. They couldn't have any previous virologic failure on a heart regimen, and CD4 counts had to be over 350 cells at entry. The primary outcome was time to viral load failure confirmed over a 48-week period, and the predefined non-inferiority margin of 12% for the difference in failure rate between short cycle therapy and continuous therapy by week 48 was set. A range of secondary outcomes were explored in this study, including HIV viral load less than 50 copies per mil at 24 and 48 weeks, changes in CD4 counts, new B or C events or death, and the adherence and acceptability over the study period. We also looked for emergence of resistance, for toxicity, and for what changes in ART regimen were required. Change slide, please. This study was open to enrollment in 2011 and closed to enrollment in June 2013. Over that time period, 199 young people in 11 countries, just over a third from Africa, about a fifth from middle-income countries, and the rest from Europe were enrolled. Now, because there were initial concerns about the safety of this strategy, it was a pilot phase in which the first 32 young people were enrolled, and they had more intense monitoring, and that data was reviewed by the Data Safety and Monitoring Board before enrollment to the main study. Ultimately, there were 99 young people enrolled in the short cycle therapy arm and 100 young people in the continuous therapy arm. In short cycle therapy, they could elect to take either a Friday, Saturday, or a Saturday or Sunday night off therapy, or in some situations, they might choose 2 other days in the week if there were compelling reasons to do so, but they kept the same 2 days off throughout the study period. And the follow-up then was as scheduled week 4, 12, 24, 36, 48, every 12 weeks to the trial end. Next slide, please. Of the 199 young people, just over half were male, and the median age was 14.1 years and ranged up to 17.6 years at enrollment. Now, interestingly, although this might be seen as a children age adolescent study, 21%, next, hit that there, 21%, sorry if you can forward because that highlight there, were over 18 years of age. In terms of baseline parameters, they were very equal between the groups, with the only exception being that there were some more CDC events in the continuous therapy arm than in the short cycle therapy arm, but there was no difference in CD4 count at time of enrollment. Next slide, please. I'm sorry, this isn't responding to, okay, thank you. It was important. Something is coming across on my computer. There we go. It was important in this study to make sure that the young people remained adherent to the strategy to which they were randomized, because if those randomized to continuous therapy decided to take a break, then the outcomes might be the same, but it would be because we're comparing like with like. However, in this study, there were 3 independent indicators that confirmed that there was adherence to the strategy. The first were the adherence questionnaires, and these were self-reported adherence questionnaires where the young people claimed to take more than 95% of their scheduled drugs, and there was no difference between arms. And the mean percentage of days on antiretrovirals, as you can see, was 72%, 72.8% for short cycle therapy, and 99, almost 100% for continuous therapy. Okay. Can you advance, please, to the next point? Sorry, can you, there. In addition, there was a MEMS cap sub-study. In this, the cap on the antiretroviral therapy bottle is electronically recording the number of openings. 61 young people were enrolled in this sub-study. 46 continued throughout the trial. And we can see that the median number of opens per week differed between short cycle therapy and continuous therapy, with 5 versus 7 days. And graphically there, you can see they spread across the week with the drop at the weekends. The reason there's a little bit of spread there is because some of the people elected to take 2 days off during the week. And the third parameter that supported this was when we looked at the MCV levels among those patients who were taking zidovudin. About half
Dr. Butler, we lost you for a minute. Hello? She's blinked. Hello? I think we lost Dr. Butler. So apologies. Dr. Butler, you can try logging back in. That might help. Dr. Butler, I think you're back. Hello? Dr. Butler, can you hear us? Can you hear me?
Yes, I can hear you.
Okay, you're back.
Okay.
Thank goodness, yes. Okay.
Okay, sorry about
It's okay.
Okay, so with regard to the primary endpoints, I'm not sure if people heard that point. In short cycle therapy, there were 6 participants who reached the primary endpoint for an estimated probability of failing of 6.1%. In continuous therapy, there were 7 who reached the primary endpoint, the estimated probability of failing of 7.3%, which meant that there was a difference of 1.2% in favor of short cycle therapy. Can you advance, please, to the next point? Can you advance?
We're on slide 9.
Just advance to the next point. It's still slide 8 on my slide.
Oh, okay. Which point? Which slide? We're on slide 8. Which slide do you want?
Slide 8. The second one. Slide 8.
It's on slide 8.
Yep. But there should be the animation should come in. There's another point on slide 8.
Well, this is. Yeah, the slide. That's the slide 8. There's
graphics.
No additional. Yeah.
The graphics. There should be graphics on slide 8.
Yes,
no?
there are.
Okay.
Mm-hmm.
They're not showing up. Okay, well, maybe I'm just not seeing them. But if you can see the graphics, on the Kaplan-Meier curve, it shows that there is no difference between the 2 arms. And on to your right on the slide, it shows where the the difference falls well within the non-inferiority bound of 12%. Okay, if we go to slide 9.
We're on slide 9.
It's not showing up on mine. Okay. If can other people see slide 9, I can just talk through them if you like.
Yes, slide 9 is showing.
So, okay. In terms of secondary endpoints and the emergence of resistance, there was sequence of the 6 who reached the primary endpoint in the short cycle therapy. Sequence was available on 3, and in continuous therapy, it was available on 6 of the 7 who reached the primary endpoint. The reason the sequences weren't available in the others was because of very low viral copy number. All 4 young people who failed without sequence data actually resuppressed after reaching the primary endpoint, which meant that resistance was unlikely in them. Of the others, there were some resistance mutations detected in 2 of 3 on short cycle therapy and 5 of 6 on continuous therapy, primarily NNRTI mutations, and the only NRTI mutation that was seen was the M184V. Okay. If we can move to the next slide. And you'd have to tell me if slide 9 is showing.
Yes.
Or
slide 10 is
okay.
showing.
Slide 10, okay. With regard to the secondary endpoints, there was no significant difference in CD4 or CD8 counts or percent, and no difference in the lipid profiles, with the only exception being a transient increase in LDL cholesterol at 24 weeks in the short cycle therapy arm only. Platelet counts, interestingly, were a little bit lower in the short cycle therapy arm at each follow-up visit. They were significantly lower, but only by about 10 counts. So it's unlikely that that was clinically meaningful. Okay. Next slide, please.
Next slide showing.
Okay, with regard to changes in ARV regimen, there were 4 changes in regimen in the short cycle therapy arm compared to 11 in the continuous therapy arm. And you can see there that the numbers remaining on the original schedule was very high, 96% short cycle therapy and 88.9% in continuous therapy. In fact, in terms of changes, there was only 1 change for virologic failure, with changes being for other reasons, including simplification or toxicity. 8 individuals changed strategy in the short cycle therapy arm, moving from 5-day a week to 7-day a week. The 6 because they reached the primary endpoint, and that was per protocol. 1 because of an adverse event, gynecomastia, and 1 who, although they remained suppressed, they had admitted non-adherence and people were concerned, and so they changed them back to continuous therapy. Next slide, please. And slide on safety showing?
Yes.
Okay. With regard to safety, there were no deaths or CDC stage 3 events, and no difference between the 2 arms, with the exception that there were some more ART-related adverse events in the continuous therapy versus the short cycle therapy arm. So there were no significant differences in number of young people with adverse events. Some evidence of more ART-related AEs in the continuous therapy arm than in the short cycle therapy arm. And the only serious adverse event reported more than once was spontaneous abortion. Additionally, just of note, there were 5 pregnancies, 1 in short cycle therapy and 4 in continuous therapy. Next slide, please. In the next slide, we see the slides of the results we asked people at the beginning of the study what things they found difficult before the study, and then we asked them the same afterwards. And over the range of items there was a trend. Most people found improvement over the course of the study, but the only difference that reached statistical significance was going out with friends, which was significantly easier at the end of the study than at the beginning. But overall, young people found this a very acceptable strategy, with 74% of young people saying that it made things a lot easier and 16% saying it made things a little easier at the end of the study, compared with 63% in 16 at baseline. Next slide, please. Part of the aims of this study was to really see what the impact on quality of life of the young people would have. And there is a parallel social science sub-study which is carrying out a series of interviews on participants at enrollment through the study, and will be completed after the study and dissemination of information has occurred to see what true impact. And it's very interesting as to some of the data that's emerging from that. While the young people liked the strategy and felt their social life was better, one of the things they mentioned was they found that side effects were less at weekends, and they were side effects that often hadn't been previously disclosed because they really only recognized them fully when they took the break in therapy at the weekends. There were some caveats. It did take them some time to adjust to the new strategy, and felt that that could cause they might need some support during that period. And it was a strategy that might not be suitable for all young people. Next slide, please. So in conclusion, 94% of all young people remained virally suppressed to less than 50 copies per mil over a 48-week period, with 97% remaining suppressed less than 400 copies per mil. Over that period, between short cycle therapy and continuous therapy, there was a 1% difference in viral suppression rates in favor of short cycle therapy. All of the primary and alternate analysis were consistent. There was no evidence of major difference in toxicity parameters, except that there were more reported ART-related toxicity in the continuous therapy arm. There were no differences in clinical, immunologic, or virologic parameters. And I didn't dwell on it with the slide confusion, but there was a biomarker sub-study with a whole panel of biomarkers to look for any change in inflammatory response, and no difference was seen. There was, however, a 27% reduction in drug exposure, and acceptability questionnaires favored short cycle therapy. And the one caveat is that this was in a select group of young people who were very adherent to their regimen before starting therapy. And it's important that we follow this out longer than the 2 years before it will become sort of a generalizable strategy. But non-inferiority of viral load suppression in young people on efavirenz-based HART, first-line ART, was demonstrated in breather for short cycle therapy versus continuous therapy. Thank you, and apologies for confusion and slides, etc.
Thank you, Dr.
Am I
Butler.
lost again?
No, you're not lost. Thank you, Dr. Butler. We will turn it over to our Q&A session, and I'd like to introduce Nandita Sugandhi, who is a pediatrician and clinical advisor for the Clinton Health Access Initiative and has done some work for WHO as well, and was instrumental in helping us to organize this webinar. So I'll turn it over to Nandita to moderate the Q&A session. Please send in your questions either through text, or you can feel free to verbally ask your question as well. So over to you, Nandita.
Thanks, Jessica. I think I'm going to focus, I have a couple questions for the two presentations, but really first of all, I want to apologize for some of the technical difficulties we're having, but based on the really the story that we're trying to tell here when we go back to look at all the abstracts that are being presented is that we have some really effective interventions for preventing mother-to-child transmission of HIV and for treatment. And I think hopefully we'll be able to get Lynn back on the line to go through some of the additional studies that were presented. But what we can really see is when some of the linkages don't happen, this is really not sort of a partial credit type of scenario, in that we're missing people in some of the cracks. I actually had a couple questions for Dr. Mammon based on the survey from MSF. One question I had is just looking at sort of the number of women who were not detected in pregnancy, and when we looked at the one slide showing sort of incident HIV infections that were picked up in the household survey, and it was significantly higher in Kenya. And I'm curious if you had a chance to look at whether those new infections that were picked up during the household surveys, were those women who hadn't been tested in ANC, or were those mostly incident infections? And I think we're sort of starting to think more about the high-risk scenarios that we need to pick up for PMTCT.
Okay, thank you for your question. I mean, if in Kenya we found so many women that were newly diagnosed at the time of the survey, our main hypothesis is that these women, most of them, they were tested at ANC. It's just that in Kenya the incidence was so high that a lot of women got infected between ANC and the survey.
Okay, no, that's very interesting, and I think that we've had, there have been discussions about where do we need to pick up, where are we missing women, and I think that making sure that we're thinking about incident infection and retesting, this sort of study highlights the importance of that. I'm just wondering from the group, are there any other questions for the survey? I'll just give a few more minutes, but in the meantime, then I think we can talk about the breather trial. And again, this was something that the pediatricians were very excited to hear about. And again, we're still seeing a lot of new pediatric infections and looking for ways to effectively treat. And I think when we go back to some of the other abstracts, we're really showing evidence of the success of early treatment and continuous treatment in children. But we do need to find ways to improve adherence and make sure that there's sort of a lifelong adherence. And so it's very interesting to think about this treatment interruptions or short breaks, or these sort of drug holidays from breather. And for Dr. Butler, I'm one of the questions that I also had from this trial was sort of, you mentioned that this was sort of a selected group, and I'm curious about those that were not included. How many of your patients were concerned about taking a break, and were not. I know that this is a group that was comfortable sort of adhering to their medications and felt confident in their ability, and were demonstrated this through over time. And I'm just curious about the exclusion, the patients that were excluded, and was that mainly because they did not feel comfortable with taking breaks, or was it more because they weren't as adherent?
Well, by protocol entry, the only people who were eligible for enrollment were those who were adherent and had been virally suppressed. But within that group, there were people obviously who elected not to enroll in the study. And yes, there were those, primarily parents, I would say, who were concerned that by taking breaks that it might upset the message that they were given, and that there might be a creep in the amount of breaks that they were taking, and that would get progressively longer. But one of the things that was interesting in the study was over the course, and because of the time of enrollment, actually the median length of time in the study was over 8 weeks. There actually was no slippage in the adherence over time. So that didn't seem to happen. But yes, I mean, people were concerned, particularly in light of the SMART trial. And when you hear treatment interruption, then that has become almost a bad word. But I suppose in a way, this was a break in drug take, but it really wasn't a treatment interruption, because we were exploiting the long half-lives of the study drugs. And I suppose that's what we need to focus on, particularly for teenagers, and looking to the future, maybe even getting those drugs with very long half-lives extending out to a month, so that they could get a monthly injection and remain suppressed as they go through their adolescence and their inability to stick with a daily regimen.
Yeah, no, I think it was very telling that one of the sort of some of the feedback that came out of the study was that it was much easier for them to spend time with friends and have those weekends off, and And so I think we're all looking for these sort of promising strategies to improve adherence. But it looks like there are actually a couple questions. I think maybe Serena, if we wanted to start with the question for Dr. Butler about the difference in the number of blips between the two arms. Dr. Butler, are you seeing that question?
Sorry, sorry. Was there a difference in the number of blips in the breather study? We're looking at not only just the numbers, but also looking at those who did have it, what the level copy numbers are, and some of that detail I don't have to hand. There weren't number of difference in blips over the first 48 weeks between these two arms.
Great, thank you.
But we'll be getting more detail on that. Will be emerging.
Fantastic. And I think it sounds like you also had a question about retesting. And this.
Yeah, I was just wondering, I'm interested in the PMTC surveillance study, and wondering whether there's a way of targeting groups for retesting in the later stages of pregnancy, because it's one of the areas where we get residual vertical transmission, or the seroconversions in pregnancy or in later pregnancy. And whereas in the developed world, doing that isn't really cost effective because the numbers are low. But I'm just wondering, in countries such as Kenya, Malawi, is there a group that could be recognized and targeted for repeat testing?
That's a really good question.
So it's exactly what our that's very operational, and because it's exactly what our field have asked us to do now. It's there is recommendation from WHO that you need to test women and their babies at any time they come, but practically it's very complicated, because the question is not what to do but where to start. And so this is actually what we are doing at the moment. At the same time, when we are piloting these interventions, we test children everywhere, and we also include point of care early infant diagnosis in order to speed up the process. And then we will answer to this question. But the issue is you need to have a global picture. For example, in Kenya, as for example, delivery was not free, the majority of the women was delivering at home, for example. So at home, it's very difficult to test the women because you cannot really access them. So it's all these questions regarding that also care, woman care and mother care, that needs to be answered. So obviously for us, EPI is a very important, and especially the measles vaccination at 6 months. If the coverage is high, it's a good opportunity to catch the baby and the mother who might have been infected during this long period between the first vaccination or the postnatal care and 6 months. Thank you.
I guess one question that I have is in the I think this in the survey, were most of the women who were tested in ANC, were they tested, sort of once in ANC, or were there women who were there programs that were testing at delivery or at later time points in pregnancy?
Usually, so we are looking at this data, meaning that we know if women have been tested at ANC, and then we know when they have been last tested. And at this time, none of the program had implemented the new guideline to retest the woman. So few women have been retested regularly after the first ANC.
Yeah, it would be interesting to see once that's implemented if that sort of type of household survey would change, if the results would change. But thank you. Are there any other questions for either of the presenters?
I think there was a second question from Serena of Mozambique regarding the breather study. Do you see that? Were there any difference in the results of breathers across young people from different countries?
That's a really interesting question, because at a number of levels we thought there might be, and actually there wasn't. There's no difference across either in terms of adherence, in terms of the problems. It was very uniform. It was one of the very interesting outcomes of the study, that young people in the different parts of the world in this really global study, they all have the same issues and respond the same way. Thank you.
Hello, can you hear me?
Yes, we can hear you.
It's Andrew from CDC. I have a question for Dr. Butler. I'm kind of concerning the regimen change. I see that you have multiple regimen change here for the short cycle therapy. There are 4 and then 11 for the continuous therapy. Why is it that high? And I know you try to state some, some reasons in the slides and all that. That why multiple regimen is such a short time?
Okay. One of the main reasons for regimen changes was a simplification. A lot of the children started on 3TC and zidovudin, and some of them changed off. They changed their nucleoside backbone purely for simplification, or going to a once daily regimen or something like that. So there was only one change for virologic failure. So most of the regimen changes were in that nature.
And there's just a last comment from Serena in Mozambique, who says, in Mozambique, there is retesting of women every 3 months during pregnancy and breastfeeding. So she was curious to know what are the policies in other sub-Saharan African countries. If there's anybody who'd like to share either now or later, we can always continue the discussion online in a virtual discussion as well, if there's a lot of interest, and continue to ask the researchers more questions if that is of interest to others. But if anyone has a quick comment on what other policies are being implemented in other countries, feel free to chime in. Okay, or you can feel free to also type in any response. So without further ado, are there any more questions, Nandita, on your end?
No, I'm wondering if it's possible for us to get Lynn back.
Yes, Lynn is connected, I believe. Lynn, are you there?
I am here.
Okay. Yeah, it's still quite patchy.
Well, is that better?
Yeah. No. No.
Well, I don't know what to do.
Yeah. Okay. Nandita, do you feel comfortable going through some of the slides? Hello?
Yeah, hi, Jessica. Yeah, I know I can. I'm just, the other thing too is I want to make sure we don't run out of time for our other speaker. Were we able to get Baylor, Uganda, and Dr. Addy on?
No. No.
Okay.
No.
Okay, I'm wondering then maybe we can go through some of the others, or if there's anybody from. I'm actually wondering because I think some of the authors from the various abstracts are on the line.
Yes.
And I'm wondering if we could ask any of them just to briefly give an overview as we go through. Otherwise, I'm happy to speak about them.
Sure. I think there are quite a few who are online. So Dr. Kramer, Dr. Njunga. Are you there? Hello? Yeah, Nandita, I think it's okay to go ahead.
Sure. Are you able to advance the slides?
Yes, or you can also take over. I can turn it over to you. Do you see that up top where you can take over as presenter?
Yes, I can. Okay. Well, what I'm going to do is I'm going to pause at each one and see if any of the authors are available to speak and give them a chance.
Okay.
because I think that would probably be slightly more
Yes.
informative than to have me go through them. But really, I'm just to touch back. We really want to give an overview, sort of starting at kind of the evidence that we have of the success of PMTCT. We looked at the Cabello study and some evidence as well as some evidence from the French perinatal cohort, looking at the success of ART in preventing transmission when treatment was started early. And then we moved on to Botswana, where we saw that, and I think this is where we paused before, and I'm wondering if anybody from Botswana is on the line.
Yeah, I don't think so, Nandita.
Okay. Well, this study was really looking at the trends over time with the transition from option A to option B, and we saw that there was, a significant decrease once option B was implemented. And again, I wanted to point out that this was in a mainly formula-fed population, and again, we've been thinking a little bit about where are the gaps in PMTCT. And I think we're seeing from this study that really, at least for the antenatal and intrapartum period, starting treatment has been remarkably effective. And when we do this at a population level, we're seeing a significant decrease in new infections. And if we move to the next study, one of the concerns has really been about the safety of ART. We've recently started using a tripler, or tenofovir and efavirenz-based regimens, and I think that was really the strategy that enabled us to implement a B+. And so from this data that was presented, we really saw some reassuring data that there were, if anything, improved outcomes with the use of a tripla for PMTCT. And so we didn't see worse outcomes, and if anything, we saw fewer improved birth weights with the use of tenofovir. I'm just going to pause here to see if anybody has any questions or comments. We can hear you. You're a little faint, but we can hear you.
Nandita, Lynn.
Great, thank you.
Yeah,
no,
yeah.
I think it's helpful to have Lynn's comments.
Okay. So, are there any other comments? So Lynn is basically saying there were higher adverse pregnancy outcomes overall, but efavirenz ART was not worse.
Exactly, and I think this was sort of reassuring for people to see. And any questions or comments? And again, it doesn't sound like we have anybody from any of the presenters. But I think we can connect people by email and through ongoing discussion. So if any questions emerge, then please send them through to myself or Jessica, and we'll make sure that they're addressed. But meanwhile, we're going to move on to the next section on more about pediatric HIV infection and treatment. And this was an abstract that I actually found very interesting, showing the systems gaps that result in late diagnosis. And I think we've been talking about some of the gaps in PMTCT. And if we look at, this was a study that came from Kenya, looking at children who were diagnosed in the inpatient wards, and where they where the gaps were when infection probably occurred. And so when we looked at the results from this, what we really found that I think it was something like about, again, when we were talking about incident infection, I think 72% of the mothers in this study had tested during pregnancy, and about half of those had tested negative at that time. But what was also interesting is that, for those children who were later tested positive, previously about half of them had been tested before as well, and of those, half had been tested positive. So again, I think this brings up the question of how much transmission is occurring through incident infections, and how many infections are occurring through breastfeeding. And again, that's a question that I would have for some of some of the abstract presenters. I don't know if there's anyone on the line from that could speak to this. But again, I think we picked this one out really because it was demonstrating, I think the point that we're trying to sort of, that we're realizing is that with these gaps, we're sort of really missing our target. And so I think this was an interesting one to look at, to show, where is it that we're missing these kids.
This is Lisa Cranmer. I'm not sure if you can hear me. Did you have a question about the abstract?
Oh, fantastic! Thank you for joining. Yeah, actually, I was sort of one of the things that I looked at when I was looking at this was sort of, again, I was sort of struck by how many of the mothers had previously been tested negative, but also how many of the kids had tested negative before testing positive. And so I guess one of the things that stood out to me was sort of the whether or not this was really looking at more transmission during incident infections, or was it more postpartum infections? And if you had looked at that, look at the number of kids who had tested positive, initially had tested negative, and if their mothers had been tested positive or negative during pregnancy.
Right, that specific subset, I couldn't speak to that right now, but I think, that overall that we are just seeing these gaps where a lot of the moms are reporting that they were tested negative during pregnancy, and that there is this time gap during which, acquisition occurred some point in late pregnancy or postpartum, and that a lot of these children are either, getting to the hospital and not being tested, or, at that time, or acquiring it during breastfeeding. So I think we can't speak exactly to answer some of those questions, but that really would be the next study to investigate at one specific time point. So we did a questionnaire when the children were enrolled into our study, and the mom reported when she was tested, and so we only have per mother report what her testing results were.
Great, thank you. Since we have Dr. Cranmer on the line, are there any questions from the audience? Okay, I realize we're not going through these in so much thoroughness, but if there are questions that do come up, please do feel free to send them out. And moving on to the next slide on immunodeficiency at the start. Again, I'm just going to pause and ask if there's anybody from the study that's on the line. Okay, I'm going to take that as a no, unfortunately. But I think, again, this was an abstract that really highlighted sort of the impact of changing eligibility. oh, sorry, I moved too fast. But if we looked at this, this was really looking at the level of immunodeficiency at the start of ART, and I think this is not coming up on the slide here, but really, if we think about the time points at 2006 and 2009, essentially, when eligibility for children changed, we can see that in some settings, immunodeficiency there was not as high a percentage, but still in a lot of the lower middle income countries, we've seen some change. But again, I think when we think about, we're not seeing data here from the more recent 2013 change of all children under the age of 5. We're still seeing significant amounts. And so I think this was an abstract we selected to highlight that children are still starting quite late. Great, and I think Lynn is also sort of making the same point that we are seeing some improvement, but I think we still have a ways to go in terms of identifying children earlier. Any comments or questions from the audience? Okay, and we're going to move on to the next study, which is the SHARE sub-study. Now, this was the study that demonstrated that early ART decreased mortality by over 70%, and this was, the study on which we the eligibility criteria was changed so that all children under the age of 2 would be eligible, and again, we then revised that to all children under the age of 5. And again, with all the interest in sort of cure or functional cure, I think there's been a lot of interest in how early treatment impacts reservoir size. And so this was an abstract that looked at that and really demonstrated that with early treatment, the latent viral reservoir was significantly lower in those that were immediately initiated on ART compared to those that were deferred until they were clinically or immunologically eligible. Part of the SHARE study also looked at treatment interruption, and one of the things, again, that was highlighted in the study is that while those that were initiated immediately on ART had sort of lower viral reservoirs, that benefit actually sort of was lost once ART was interrupted. And so it really, again, speaks to some of the need for really maintaining lifelong adherence and coming up with new strategies to support that. Okay, and I think that I'm just going to go through, the next two pretty quickly. Again, we wanted to stress here that there are benefits, some of the benefits for starting ART early. And again, I'm just going to pause and see if there's anybody on the line from the CHAPAS 3 study that would like to speak to this.
I don't think so, Nandita.
Okay, unfortunately not. But again, so this abstract, as well as the next one, was really looking at some of the cardiovascular changes in HIV-infected children. And so it really looked at, they were sort of looking at HIV positive as well as negative populations, showing that they had significantly poorer cardiovascular sort of function against their age-matched controls, but after starting ART, there was significant improvement. And so really this study sort of demonstrated that some of the structural and functional changes that may be caused by sort of HIV-related infections can be reversed and improve significantly with early ART. And I think this was a very similar sort of finding in the next in the next slide. And again, this was looking at markers of inflammation. And again, when we looked at ART experienced children against an uninfected control, ART naive, ART experienced and uninfected controls, we found that there was significant improvement in those markers of inflammation in those children that were started. So again, this is sort of accumulating evidence throughout that early ART for children is a good thing. And the next study, again, is sort of the long-term outcomes of those children. And I think this was a very interesting study that came out of the P1060 trial. And I'm going to pause here because I think this was also a very important study. So I wanted to know if there was anyone on the line who could speak to this. Okay, so I will do my best to go through this. So for this, as many of us might remember, the P1060 study looked at the difference between initiation for children on nevirapine-based regimens versus lopinavir/ritonavir. And there were two arms of the study. One group were those children who were exposed to PMTCT, and another group had not been. And initially, I think in the last couple of years, there was evidence that came out of P1060 that even those children that were not previously exposed to NNRTIs through PMTCT still had better outcomes and improved survival on LPVR-based regimens. And it was on the basis of this study that the recommendations were changed in 2013 to recommend lopinavir/ritonavir for all children under the age of 3, regardless of prior exposure. So this was really the study showing the long-term outcomes of these children. And so initially, the first study showed sort of improved mortality. And this, I think, went out to, I'm not sure. I'm trying to remember now. I don't have it in front of me. The length of time it went out to. I think it went out to 84 months here from looking at the graphs. But one of the things that had been raised in the earlier study or earlier in the study was the difference in growth, and that we saw that those children who were on nevirapine had better growth and CD4 recovery. However, when we looked at this over time, and I think this is something that that showed that over time those differences really became insignificant. And so again, we're showing that LPVR over time is superior to nevirapine-based regimens. And I think just in the interest of time, and again, because we're ending on the lopinavir/ritonavir sort of 1060 results, I wonder if we want to talk about CHAPAS 2 and move ahead to the presentation that was from Baylor. Jessica?
Yeah, Nandita, they're not connected.
Okay, would it be okay if I went through those?
Yeah, of course, yeah.
I'm very interested in.
Of course.
So I apologize to everyone. We're gonna the study that Lynn was also hoping to present was the PROMISE study, looking at the efficacy of triple ART for PMTCT compared to AZT, particularly in high-risk women. I think we're going to skip that, though the slides will be available with a lot of the data from the abstract. And if any questions come along, again, please feel free to send them through. But I think what we're going to do in the interest of time is move ahead to the what was meant to be the last presentation, I think, just so we make sure to cover it. And I wonder if we could pull those up. Let me, Jessica, I'm going to turn it back over to you to do that. But in the meantime, are there any comments or questions from the group?
Nandita, you want me to pull up the CHAPAS slides?
Yes.
Okay.
And I think the reason why, we thought this was a really interesting study to present, and it's unfortunate that no one from the Baylor team or JCRC is available, because I think there's been a high interest in sort of the lopinavir ritonavir sprinkles or mini tabs or pellets. And those of you who sort of know me know that this is a topic that is very near and dear to my heart, to think about these. But, overall, what we've really seen through these abstracts and a lot of the data that's been coming out of CROI is that, again, we're still seeing a lot of new pediatric infections, but we know that early treatment is effective. But we still have challenges, and we really need better formulations of drugs and better strategies to promote adherence. One of the challenges, of course, in providing lopinavir ritonavir-based treatment, particularly to young infants and younger children, is the difficult formulations that we have. And so this is sort of the results from the CHAPAS-2 trial that went on in Uganda. It was at 2 different sites. There was earlier data that looked at the pharmacokinetic data from comparing the syrups, the pediatric tablets, and the pellets, and some of the acceptability data. So this was sort of a very elegant design. It was a randomized 2-period crossover trial in children who were HIV infected. There were some infants in this group as well. Some of the children were ART naive, and some of them had been on treatment earlier. So there were 3 groups in the trial. There was Group A, which were those infants aged 3 months to less than a year, who were initially started on syrups for 4 weeks and then were switched to what was being called the mini tabs at that time. There was Group B, which were the children aged 1 to 4, and again, they started mini tabs and were switched to syrup over time. And then there were those that were age 4, and those that were able to swallow tablets actually started the 125 milligram pediatric Alluvia tablets, and then were switched to mini tabs. At the end of week 8, all of the groups were able to choose which formula to continue. And it was so this is actually not the abstract that was presented. This was presented in an earlier conference. It was very interesting to look at the acceptability data sort of at the end of the 8 weeks. And we can go back to that and discuss a little bit, but I think in this study they really looked at sort of the longer term for those children that chose to accept to continue the pellets after the study ended. And there was also some viral load measurements that were done at week 48 in those children. So when we looked at the proportion of parents, of caregivers who were preferring pellets, what we see here is that in the younger age groups, at enrollment, there was some hesitation. Less than half of the caregivers really thought that the pellets would be acceptable. But that increased over time, especially in those younger age groups, but not so much for the older age groups where they were taking the tablets. But it diminished somewhat at week 48 in those patients. And when we look at the reasons why, I think this is unfortunately a little bit difficult to look at, and I'm actually having some trouble reading as well. But if we looked at in the youngest age group what some of the sort of complaints or the challenges were with the different formulations, this is comparing the syrup to the pellets, and we see that in terms of taste and swallowing, the difference in I guess sort of both the syrup and the pellets had a poor taste, and therefore, I think that was one of the biggest challenges for this age group. Swallowing was not as difficult for the pellets, but there were some concerns about vomiting the formulation, and there were also, because this is a formulation that needs to be mixed into soft foods or a little bit of milk, there was concerns that the child had not been able to take the entire dose. So these were, again, some of the comparisons based on the perceptions of the caregivers of the 2 formulations. And moving on, this is sort of the next group, the group B of the children who were aged 1 to 4 years. And again, taste, swallowing, and taking the whole dose presented a little bit of a challenge for some of the caregivers. And lastly, when we look at the pellets versus the tablets, and again, these are in children that were able to swallow the tablets, the taste, swallowing, and sort of the losing or breaking the bottles of the pellets were some of the challenges here. Taking the whole dose again was raised by a couple of the caregivers. And so overall, we can see that, in some cases, the pellets really do provide an improvement over the syrup, but for the vast majority of those older children preferred to take the tablets once they were able to swallow pills. And I think this one was really showing over time. Sort of the proportion of patients that had chosen to stay on the pellets. What was interesting about this was that there were 2 different clinics that were running the study, and my understanding is that some of the children at JCRC were slightly older than those children at Baylor, or PIDC here on the screen. But we saw that there was kind of a significant difference in the number of children who chose to remain on the pellets across the 2 clinics. And so in the in the age groups, I think in the group B, or the middle age group, more children chose to stay on the pellets over time, and were at JCRC compared to the PIDC or the clinic. And so this really sort of highlights, again, when we think about this formulation, that needs to be administered in a specific way. It really sort of highlights the importance that the healthcare worker plays in providing guidance to caregivers about medication administration. So this is, again, a promising formulation that has been highly anticipated, and we're hoping for more data to come. But we thought it was important to present to this group, sort of just to think a little bit about acceptability, but also sort of preparations for how we think about the use of this formulation once it becomes available. But one thing that was reassuring from this is that out of the children, I think about 19 children had viral loads done at 48 weeks. These were the children that were on the pellets, and all of them were below 1,000 copies per ml. So we do know that despite some of the challenges in administration, that this was effective in keeping the viral load down. So overall, I think pellets were more acceptable than the syrups, earlier on, but over time, I think that there were challenges that emerged around taste and administration. But there was really a difference between the 2 clinics that really reflects some of the perceptions that the healthcare workers may have in the instructions that they may give to parents. But we really do think that thinking about formulation is an important part of acceptability and promoting adherence. And so again, I think the reason we wanted to raise this is because this is something that we know is sort of in the pipeline, and that we need to be thinking about how we want to best implement the use of this. So I think that brings us sort of to the end of the abstracts that we were hoping to present. But again, I'm wondering if there are any comments or questions from the group. We have a little bit more time for discussion. So I'm not seeing any questions come up, and again, I apologize for the technical issues that we've had, but I'm hoping we will, share the slides with all of you. I think Jessica will put those together and send them out. But if any questions, in reviewing those, if any questions do come up, please do send them on, and we can continue the conversation online.
Yes, just to summarize, I think we will send out the presentations and the recording of the webinar as well. And we'd encourage everyone to continue to send in their questions or share experiences via the IATT community of practice. I think that's been a engaging forum to exchange lessons learned. Many of the studies that were discussed have practical implications for programming. Perhaps countries can share their experiences and policies around repeat testing of pregnant women, which was a significant issue, as well as any questions or comments around the other studies, which will definitely affect programming in the future. So if there are no questions, I'd like to thank all of our presenters, Dr. Moffason for preparing the slides and summary of all the abstracts from CROI, and to Dr. Butler for her presentation on the breather trial, and for Dr. Maman on his presentation on his study on HIV diagnosis in pregnant and breastfeeding women. So we thank you for the time you took to, out of your very busy schedules, to be with us, and for all the other researchers who are able to join us. We want to continue to do webinars like this in the future, where we're reaching out to many of the researchers on the ground who are conducting similar studies related to PMTCT and pediatric HIV. So definitely feel free to send in any questions. Dr. Addy, also from Uganda, can take questions about the TRAPPIST-2 study as well. Thank you, Nandita, for moderating and for giving the presentation in Dr. Moffason's place. And again, thank you to all of our participants for your patience with some of the technical difficulties.
Thanks, Jessica.
Yeah, thank you. Thank you.
Thank you.
Have a good day.
That's it. Bye-bye.